Hello everybody, my name is Tariq Lolah. I'm one of the A&E doctors in Leicester Royal Infirmary, and welcome to my lecture about basics of mechanical ventilation. So first of all, I want to say who will benefit from this lecture. So actually anybody starting his career in A&E or in intensive care unit should benefit from this lecture. So this lecture is not meant to tell you all the details about mechanical ventilation. It's not meant to tell you all the details about the modes of mechanical ventilation. It's not meant to tell you about the initial settings, for example, how much should be the tidal volume, the respiratory rate, because actually everybody can read this. So this lecture is targeting the part of the mechanical ventilation that not everybody can understand and not everybody can digest. It's necessary for emergency physicians actually to know the basics of the mechanical ventilation, because most of the time the patient got intubated by the intensive care team. However, if intensive care team are busy and you got to intubate somebody, and if the patient will stay ventilated for a few hours before preparing the bed in the ITU or in the ICU, you should know about the basics of mechanical ventilation. We'll speak about the basic concepts of mechanical ventilation. So actually, ventilation basically is air movement from point to point. So for example, if we have if you get 2 points, point A and point B, okay, so for air to move from A to B, okay, it needs either increase pressure in A or decreased pressure in B. So for example, if you have a tube, okay, if you need the air to move from end to end, you need either to blow on one side, okay, or to make suction or suck from the other side, okay. So for air to move from A to B, it needs either increased pressure in A or decreased pressure in B. So so ventilation is air movement, and air moves due to pressure change. So all of us know about the pressure control modes and volume control modes, but actually to know the relation between the volume and pressure, we need to quickly discuss Boyle's law. So Boyle's law states that pressure multiplied by volume equals constant. So for example, just to make it easier, 4 by 4 equals 16. If you changed one 4 to be 8, the other 4 automatically will be 2 for the 16 to remain constant. So that means in mechanical ventilation, you either choose to control the volume and the pressure will be variable according to the lung mechanics, or you choose to control the pressure and the volume will be variable according to the lung mechanics. So you can't control both of them. So that's why actually the two main ways of ventilating a lung is either to do volume controlled modes or pressure controlled modes, and I believe it's clear. So in order to understand the modes of mechanical ventilation, it will make it easier actually if we understand the types of breathing that can happen due to during interaction between the patient and the ventilator. So the first thing, which is the spontaneous breathing, which actually fully controlled by the patient. It will be just breathing in and breathing out without any intervention from the machine. The second type of breathing is mandatory, and mandatory actually can be either mandatory volume controlled or mandatory pressure controlled. In mandatory volume control, the machine controlled the volume given to the patient in a certain time. For example, if he didn't breathe within few seconds, so he would be given a mandatory controlled volume, okay, but the pressure will be variable according to the lung mechanics. However, although we can control the upper limit of the pressure that the machine can produce, and after that actually there is a specific valve in the machine that will open and allow the air to come out. So actually, but in this condition, if due to different lung mechanics, for example, stiff lung, if the pressure went very high before delivering the predetermined volume, the pressure will stop at a certain point. For example, if we made the peak pressure, the maximum peak pressure as 40, if due to stiff lung, actually to deliver 500 mils of milliliters of air, the resultant pressure will be 55, for example. So the pop-off valve will open and the pressure will stop at 40, but the volume delivered will be less than 500. Okay, so you can determine the volume given to the patient, but you can put an upper limit of the pressure that it can reach, just to avoid any parotrauma or volutrauma. The same way with the pressure control. So the mandatory pressure, the mandatory volume, which is pressure controlled, so the machine will raise the pressure inside the circle to a certain limit for a certain time, then it will drop off again to the baseline. And actually during that the amount of volume delivered to the patient will be variable according to lung mechanics. So for example, healthy lung can accommodate large volume with this kind of pressure, and stiff lung will take less volume with the same amount of pressure. So again, spontaneous, mandatory volume controlled, and mandatory pressure controlled. Okay, so then there is another type of breath that's called assisted breath volume controlled. Assisted breath volume controlled is exactly like the mandatory, but it's initiated by the patient. So the trigger will be by the patient, but once the patient reached the trigger level, so the machine will give a fully controlled mandatory breath. Okay, so it's as the assisted breath, either volume controlled or pressure controlled. It's just like the mandatory volume or mandatory pressure, but actually it's just initiated by the patient. So we can see here that the patient initiated first before the patient is being given the full volume or the full pressure that has been preset by the clinician. Okay, so we talked about the spontaneous breathing, the volume controlled mandatory, and volume controlled and the pressure controlled mandatory. We talked also about the assisted breath volume controlled and assisted breath pressure controlled. And the last thing we'll talk about actually is the pressure support. So the pressure support is some sort of assist that can be added to any spontaneous breath during mechanical ventilation. Okay, so the pressure support is initiated by the patient, exactly like the assisted pressure control, and the target is to raise the pressure to a certain value. Okay, and the same actually like the assisted pressure control. However, the difference between the pressure support and assisted pressure control is in the cycling mechanism, and this actually will be obvious in the next slide. So in order to make it easy, we can just compare between all these types of breathing together in one table. So the points of comparison will be initiation, trigger, and cycling. So initiation is how the breathing starts and who's controlling it. Is it the patient or the machine by after a certain time, for example? And the target is what exactly we want to achieve by this breath. Is it a certain volume? Is it a certain pressure? And the cycling mechanism is how the patient will stop inspiration and start expiration. So initiation, target, and cycling. So the first thing we'll talk about is the spontaneous breathing. The spontaneous breathing, as we can see, actually is initiated by the patient, targeted by the patient, and cycling by the patient. So the patient actually can control everything about spontaneous breathing. He can start whenever he wants, and he can take as much as he wants from air, achieving a certain volume or certain pressure, or actually, and also he can just stop inspiration and start expiration at any certain point. So it's totally controlled by the patient, and that's actually very easy to understand. So the mandatory volume. So the mandatory volume is initiated by the machine, by the ventilator after a certain time. So for example, if you are giving your patient mandatory breathing by the rate of 20 breath per minute, so every 3 seconds, the machine or the ventilator will give him a full tidal volume, which is predetermined. For example, 500 mils of volume, or whatever you set it to give your patient, and the target will be to give this volume. So, for example, if you set it for 500 mils, so the target is to give or to deliver the patient this 500 mils of air. And the cycling mechanism actually is volume as well. So once this volume of air has been delivered, so then the patient can stop inspiration and start he can start expiration. So the initiation is time by the machine after a certain time, target is volume, and cycling is volume. So the mandatory pressure, so the mandatory breath pressure controlled is initiated by the machine, by the ventilator after a certain time, but the target actually is to reach a certain pressure. So for example, we need to raise the pressure inside the whole circuit to a certain value, for example 20 centimeter water, but you can't put the cycling mechanism also as a pressure, because for example, once you reach this 20 millimeter centimeter water, for example, and if you reach it, switch it off immediately to expiration, so you don't have enough time actually to deliver a significant volume. So that's why actually the cycling mechanism of mandatory breath, which is pressure controlled, is time. So you need to raise the pressure inside the whole circuit to a certain value and maintain it for a certain time, which is the inspiratory time. We'll talk about the inspiratory time later in this lecture. Then once the inspiratory time finished, then the patient will stop inspiration and start expiration. So this is the cycling mechanism. So the cycling mechanism in mandatory pressure is time. Okay, so as we said that in the mandatory volume, that initiation is time and the target is volume and cycling is volume, the assisted volume is exactly the same, but the difference is that initiation is by the patient. The initiation is by the patient, and you will note this actually in the curve, that there is a bit of negative pressure initially, so that just indicates that the patient is started initiation. So if you look at the curve here in the mandatory volume, there is no negative initiation, but in the assisted volume, so the initiation is by the patient. The target is to deliver the same volume, for example 500 mils, and after reaching this volume the cycling mechanism will start, so switching of the inspiration and starting the expiration. So the same way actually, if the assisted volume is just like the mandatory volume, but the difference is that's triggered by the patient, also assisted pressure is exactly like the mandatory pressure, but it's triggered by the patient. That's why also you can see here in the mandatory pressure that only the pressure is going to a certain value maintained for a certain time, then expiration starts. It's the same here, but the initiation is by the patient, is not by the machine. So assisted pressure, the initiation is by the patient, and the target is to reach a certain level of pressure, so raise the pressure inside the whole circuit for to a certain value, and the cycling mechanism is time, so you need to maintain it for a certain time before switching it off to start the expiration. So now we talked about actually spontaneous, mandatory, and assisted. So now what is pressure support? What's pressure support? Pressure support is additional pressure that can be added to any spontaneous breathing during the interaction between patient and the ventilator. So somebody can ask actually, so it's pretty similar to pressure controlled, because actually it's also initiated, so it can be added to spontaneous. That means that it's initiated by the patient, and also it's a pressure targeted, so it's just like the assisted pressure. But what's the difference between assisted pressure and pressure support? So in assisted pressure, the breath is initiated by the patient, and the target is to reach a certain pressure and to maintain it for a certain time before switching it off to start expiration. In pressure support, the initiation is by the patient, and the target is to reach a certain pressure. That's why you set the pressure support value, for example 10 to 15 centimeter water or whatever. But how long will this pressure stay? So in assisted pressure, it's time, so it will stay there for a certain time. But in pressure support, it's not time cycled, it's flow cycled. That's why actually it's some sort of patient controlled as well. Okay, so that needs a bit of explanation. So what happens when the patient starts to take spontaneous breathing and the pressure support is starting? So the pressure in the whole circuit raises to a certain value which is preset for pressure support. When the patient starts breathing with the pressure support, the machine kind of records the initial flow the patient is breathing with. For example, initially the patient starts breathing with flow of 100 liters per minute. Okay, by the time the patient doesn't require any more air, he starts to slow down the air flow going inside. Even if the pressure is staying the same, the patient, by just fixing his the volume of his chest, just not relaxing anymore to take any more air, the flow will come down. So once the airflow comes down to about 25% of the initial flow, then the machine will switch off the pressure immediately and start exhalation. It's a bit of weird actually, but that's that kind of difference between the pressure support and the assisted breath, which is pressure controlled. So the cycling mechanism is by flow. So initially the machine measures the initial flow. For example, if it is whatever 80 or 100 liter per minute, once the flow slows down to 25% of the initial, in most of the machines actually 25% of the initial flow velocity, then the machine stops, then exhalation is allowed, and that actually makes it more controllable by the patient. So for example, if the patient is just coughing or just stiffing his chest, not taking any more air, that means actually that the flow will drop very rapidly. Then before even reaching zero, just when it reaches 25% of the initial flow, it will start exhalation. All right. So now, as long as you have understood that different types of breathing, now the modes of mechanical ventilation will be very easy actually, because it's just just alternation between these different types of breathing you just got to know about. So the first mode actually of mechanical ventilation, which is the most commonly used actually by us in A&E, and which is called actually assist control mode. The assist control mode got actually different names on different machines. So the assist control is the same, the IPBV, okay, or the IPBV assist on some machines. So that basically means that assist control, it's alteration between the controlled, which is mandatory breath, and assisted breath. Okay, so the assist control, on the machine there will be a set minimum breathing rate. For example, if you set your patient to take minimum of 12 breaths per second, if your patient is paralyzed and sedated and is not making any effort or any interaction with the machine, so the machine will give him actually for example, the 12 breaths per minute. On the other hand, if your patient is awake, as not fully awake, if your patient is actively breathing, each single trial for him to take a spontaneous breathing will be fully assisted by a full tidal volume, if this is assist control, volume control. So for example, assist control, so actually assist control can be volume control or pressure control, so it's the same. So either alternation of mandatory volume and assisted volume, okay, or mandatory pressure and assisted pressure, the same way. So assist control is the most common mode we put newly intubated patients on, and this actually available, the mode that's the default available on all the portable ventilators we use in A&E. So if your patient is not interacting at all, paralyzed with muscle relaxant, so he will be given the minimum breathing rate per minute. So for example, if you are seeing him on 12 breaths per minute, every 5 seconds he would be given a mandatory one. And if he is actively triggering, so every single trigger trial will be converted to a fully assisted breath. The next mode actually we need to know about is CMV. It's kind of historical, but we need to know about actually to be able to understand what is CMV. So controlled mandatory volume is actually in the old anesthetic machines, which actually doesn't contain any flow sensors or trigger mechanisms that can assist the patient on breathing. So it's only control. So for this mode, your patient need to be paralyzed, fully sedated, and actually the machine is controlling everything. So it's only alteration of mandatory breath. Each certain time. For example, 20 breath per minute is just every 3 seconds. It's given a mandatory volume or mandatory pressure. So mandatory every certain time. There is no interaction or negative triggers at all between the patient and the machine. That's controlled mandatory ventilation, and it's almost not available in any machine at the moment. It's just historical, but it's important actually to understand the IMV and SIMV. So now there's the next one we need to know about is the IMV, which is intermittent mandatory ventilation. So for this mode, it's the same. It's also a repetition of mandatory volume or mandatory pressure, but in between each two breaths, the patient is allowed to take spontaneous breathing. So if the patient is taking the breathing in the interval, so that's okay. If he's taking inspiration and expiration before the next breathing, that's fine. But the problem is of the IMV, or the intermittent mandatory ventilation, is if the patient is taking breathing and before exhaling, the next mandatory breath came in. So it will add a breath on top of a breath that can expose the patient to pressure, trauma, barotrauma, or volutrauma. And here comes the SIMV. So here comes the SIMV. So the SIMV, because we found that the problem of the IMV is the later part of the interval between mandatory breath, because if a spontaneous breathing came here and before the exhalation, the next mandatory breathing comes, so this is the problem. So the problem is not the initial part of the interval, it's the late part of the interval. That's why an SIMV, the interval between two breaths, or each two breaths, is divided. So the later part of the interval would be called the synchronization window, the SW, the synchronization window. So this synchronization window, if actually any spontaneous breathing happened within the synchronization window, it will be converted to assisted either volume or pressure according to the mode you're using. We're just showing the curve of the volume control. But for example, if a spontaneous breathing starts here, it will be fully assisted, and the next mandatory breath will be omitted, removed, okay, and the interval will be resetted. So this one actually will be moved here, so the interval between this mandatory and this mandatory will remain the same. And if the patient tries to take spontaneous breathing outside the synchronization window, he will be allowed totally without any problem to take a spontaneous breath, or it can be actually being given. It can actually be given with pressure support. So pressure support can be added to a spontaneous breathing here that can be given the patient can take actually outside the synchronization window. So again, SIMV is the same IMV, and the patient is allowed to take breathing in between. But to avoid the air trapping, if the patient is taking breathing here and before getting it out, it's time for the next mandatory breath. So the later part of the interval is called synchronization window. If any spontaneous breathing comes here in this window, it will be fully assisted, and the next mandatory will be omitted, and even the next one also will be moved forward, so the interval will be the same. Any spontaneous breathing outside would be either just the spontaneous breath or spontaneous breath with the pressure support. That's why you will find if you are setting an SIMV for a patient, you will be setting, for example, SIMV volume control. You will set the volume, you will set the breathing rate, you will set also the pressure support. That's why that's actually important to know. Why do you need to set pressure support in SIMV? Because the patient might take spontaneous breathing outside the synchronization window, and it will be given with the pressure support. And the best actually is to give a pressure support that will give the pressure similar to the other mandatory breath. So the main advantage of SIMV is it's actually a bit of rest of mind, especially to the anesthetics who don't want to mind actually if the patient started to wake up, starts spontaneous breathing. The mandatory will be the same. So each assisted breath will happen, another mandatory will be omitted, and the rest of spontaneous breathing would be just either given as a spontaneous or with the pressure support. But actually the main problem of the SIMV is that sometimes actually it causes increased work of breathing, and there was a famous study done by John Marini, I think in 1998. So I may be too old actually, but it's called the SIMV. It's actually concluded that SIMV is not the best mode actually to put your patient in, to put your patient on. So SIMV is not that good actually, but it's important to understand it anyway. So because we spoke about already the SIMV, which is synchronized intermittent mandatory ventilator, now we move to the modes we see in the non-invasive machines or NIV machines, NIPIs or whatever you use in your hospital. So to understand the CPAP and BiPAP, which are the main two modes available in the non-invasive ventilators. By the way, these modes also can be used on the invasive type of mechanical ventilation. So to understand the CPAP and BiPAP, we need to take it in a stepwise approach. So the first thing to understand the pressure curve of spontaneous breathing. So for example, if this is the pressure against time curve for spontaneous breathing, so inspiration will be negative, expiration will be positive, and that's actually the spontaneous breathing all the time. Okay. So the end expiratory pressure will be 0 normally. Okay. In spontaneous breathing. But if we elevated the whole pressure, the whole curve to be at a higher scale, so the whole curve up and out will be on the positive side. That's what we call PEEP. So PEEP actually means positive end expiratory pressure. So end expiratory pressure, instead of being on 0 here, it would be positive here. For example, positive 5 or positive 3 or whatever the PEEP value you're adding. So basically, that means that when the patient starts to breathe out on the ventilator or on the non-invasive machine, when the pressure reaches, for example, positive 5, if you set it, the beep to be 5, with breathing out, the pressure will initially go up and starts to come down. And instead of allowing the pressure to come back to 0, when it reaches 5, the expiratory valve will close and will keep the pressure of 5 inside. Okay, and that's actually important to recruit the alveoli and leave it open. So it's actually so if you put positive end expiratory pressure to 5, for example, the whole curve, the oscillation will not be around 0 anymore. It will be around the 5. Okay, so that's why from this point actually comes the name of PEEP, positive end expiratory pressure. The end expiratory pressure here was 0, but the end expiratory pressure here is 5. So PEEP is positive end expiratory pressure. So if we added spontaneous breathing to PEEP, that's CPAP. Okay, so CPAP is a spontaneous breathing plus beep. So this is spontaneous breathing, this spontaneous breathing plus beep, so that's the CPAP. It's just the oscillation, exactly the same like any spontaneous breathing, but actually it's not around 0, it's around 5. So keeping the minimum pressure of 5, for example, at all the time inside your alveoli, so that actually prevents lung collapse in ventilated patients. Okay, so if we added the pressure support option to the spontaneous breathing, we said that the pressure support is different from other types of breathing, that the flow, the cycling mechanism is flow cycle, so it's pretty much controlled by the patient, even the cycling mechanism. The volume controlled is cycled by volume. The time control, the pressure controlled is cycled by time. So pressure controlled, for example, even if it's assisted by the patient, so initiated by the patient, it needs to stay on a certain pressure for a certain time. So it's time cycled, but the pressure support actually is flow cycled, and the patient can control the flow he's taking the air with. So that's why actually the pressure support sometimes can be terminated or cycled very early, and can stay longer if the patient decided to take more and more air. Okay, so that's why the pressure support is different from the assisted pressure control. So assisted pressure control is, it would be all the curves will be the same width because it's time cycle, so the inspiratory time will be the same. But with the pressure support, the patient can terminate at any time by the flow cycling mechanism. So this one, for example, would be a shorter breath with a smaller volume. This one will be a longer breath with a bigger volume. Okay, so that's why the pressure support is just an option that can be added to any spontaneous breathing. So because we said that CPAP is only spontaneous plus PEEP, so pressure support can be added to this mode. Any ventilator mode with a spontaneous breathing in it, actually as an alternative or as an option, it can have pressure support. Okay, so pressure support, if it added to the CPAP, it's BiPAP then. Okay, so BiPAP is CPAP plus pressure support. So to summarize, this is a spontaneous breathing. CPAP is spontaneous plus beep, and BiPAP is CPAP plus pressure support. Okay, it's really important here to understand that pressure support, you don't control the rate. So BiPAP and CPAP, you don't control the breathing rate. Unfortunately, I still find some of my colleagues who misunderstand this point. For example, if you are putting a patient who's actually in COPD exacerbation, was raised CO2, and you want to get rid of the CO2, wash it to adjust the pH and these things instead of having respiratory acidosis, they increase the breathing rate or the respiratory rate on the NIPI or the non-invasive machine. But actually, the respiratory rate you are adding on the BiPAP machine is not an actual respiratory rate. It's a backup mode. So because this is totally spontaneous, okay, if the patient stops breathing, for example, or became apneic at any time, the machine needs to set up a backup rate to ventilate the patient with. So this is the backup rate. So increasing the breathing rate in a patient who is actually awake and can breathe, it will not change anything. It will not change your minute ventilation, because this is actually that's all determined by the patient. The breathing rate you are setting is just a backup mode. If the patient is not breathing at all, this for example, for a few seconds, this will trigger the apnea backup system, which will just give the patient sort of pressure controlled breath, just to save time for you to check what's happening with your patient. All right, so here comes actually the question we always ask ourselves about. So what's the relation between the tidal volume, the respiratory rate, the flow rate, the IE ratio, and the inspiratory time? It's a bit difficult to just explain this actually without an example. So that's why we will get the first example. So to understand this step by step, so this is the first example we will have. Imagine you get a patient, you're putting your patient on mechanical ventilation with breathing rate of 20, tidal volume of 500 mL, and the flow of 30 liters per minute. Please concentrate, because it's really important. So the things you need to understand from this: breathing rate is 20 breath per minute. That means that each cycle is 3 seconds. Each cycle that should include inspiration and expiration is only 3 seconds. Okay, and the tidal volume is 500, which is 500 mL, which is half liter, and the flow velocity is 30 liters per minute. 30 liters per minute. Okay, so 30 liters per minute means that if you divided 30 by 60, it will be 0.5. Okay, so for example, 30 liters per minute means that would be half liter in each second. 30 liters per minute. So minute, you divide the minute by 60, that means 1 second. And you divide the 30 liters by 60, that's half liters, 0.5. So 0.5 liter in 1 second, 0.5 liter in 1 second. So now actually you concluded that the inspiratory time will be 1 second. You concluded that the inspiratory time will be 1 second. And we know from the beginning that because the rate is set on 20 breaths per minute, so that means the whole cycle is 3 seconds, and now the inspiratory time is 1 second. So how long left for the expiration? It's 2 seconds, because if the cycle is 3 seconds and you took 1 second for inspiration, you get 2 seconds for expiration, right? So the cycle is 3 seconds, and here is inspiration will be 1 second and the expiration will be 2 seconds. So the IE ratio will be 1 to 2, 1 second inspiration and 2 seconds expiration. Okay? All right. Let's get the second example. So if you have, for example, the same patient and you put him on still 20 breaths per minute, which means that the cycle will be exactly 3 seconds. So 3 seconds. And the tidal volume still 500 mils, which is half a liter, and the flow velocity is 60 liter per minute. 60 liter per minute. So now the only thing we changed is that we doubled the flow velocity. So instead of 30, it became 60. That means the air will go in faster. So instead, if you 60 liters per minute means 1 liter per second. 1 liter per second. So how much will the half liter take to go in? Half second. Okay. So the inspiratory time, if instead of being 1 second, it would be only 0.5 seconds or half a second. So the inspiratory time is 0.5 seconds or half second. And we said before that the cycle is 3 seconds. So here's the cycle. If half a second is taken for inspiration, how much would be left for expiration? It's 2.5 seconds. So 0.5 to 2.5. Okay. So how will be the IE ratio? Exactly, it would be 1 to 5. 1 to 5. So this is actually how will you manipulate the IE ratio. So in the previous example, the IE ratio was 1 to 2. Now it's 1 to 5. It's only by changing the flow velocity or the flow rate. Another example, we will just quickly discuss. So in this example, the breathing rate is 15. Breathing rate is 15 breaths per minute. The respiratory rate. The tidal volume is still 500 mils, and the flow velocity is only 30 liters per minute. 30 liters per minute. So can we start calculating this? So the respiratory rate is 15. So how many seconds will be the cycle? Exactly, it's 4 seconds. 4 seconds. And the flow velocity is 30 liters per minute. So if we divide it by 60, so 30 liters in a minute, so half liter will be in a second, just by dividing both by 60. So it will be half liter per second, and actually our tidal volume is half a liter, so the inspiratory time would be 1 second. So, and as we mentioned before, the cycle is 4 seconds and the inspiratory time is 1 second. So what's left for expiration is 3 seconds. So the breathing time, the breathing time would be the expiration time would be 3 seconds. Inspiration will be 1 second. So the IE ratio will be 1 to 3. 1 to 3. Okay, so this is actually how to adjust the IE ratio. IE ratio. So for example, if you increase the flow rate, okay, the air will go to the patient faster, okay? And this actually will shorten the inspiratory time and will leave more time actually to for the expiration, okay? So another thing you can do, for example, if you decreasing the volume with the same flow velocity, it will take less time to go in. This also will decrease the inspiratory time. For example, if you give a tidal volume of 500, it takes 1 second for the in this example. If you decrease the volume to 250, these numbers actually are not practical for any patient, but it's just to be easier to understand. So easier numbers to digest, to be easier to understand how do you adjust the IE ratio. For example, if the tidal volume became half of the 500, so 250, and instead of taking 1 second to go in, it will take also half a second, and will leave actually 3.5 seconds for exhalation. So half to 3.5 will be 1 to 7, the IE ratio. Nobody actually will be left with tidal volume of only 250, except in very little patients according to their weight, okay? So now we understand actually the relation between the respiratory rate, the tidal volume, the flow velocity, and the IE ratio, and the breathing cycle, okay? Only one factor hasn't been added to this equation actually, or this discussion, which is the post-inspiratory hold, which is the plateau. So most of the ventilators offer a post-inspiratory hold just after the inspiration. The volume or the pressure or whatever, the volume, for example, will be kept in the lungs for a certain period before opening the valve and allowing exhalation or expiration. So what's actually the benefit of this plateau time or post plateau? We will actually explain why we're calling it plateau and what's the benefit of this in the next slide. Okay, so this is the pressure versus time curve of mechanical ventilation in volume controlled modes. Volume controlled modes are either, for example, assist control, or if it's called IPPV on some ventilators. Okay, so normally the pressure will go up during inspiration and go down again to 0 during expiration. Okay, if we are putting post-inspiratory hold, okay, there will be a bit of plateau here, okay, during this post-inspiratory hold. This plateau actually got many benefits. I mean, for the patient. The first thing actually is that it increases the mean airway pressure. Okay, so to explain this actually, we need to say that we have two things. If we are ventilating any patient, you got two things to worry about: CO2, okay, and oxygen. All right, so what determines the oxygen, or what are the factors changing the oxygen, and what are the factors affecting the carbon dioxide levels during the mechanical ventilation? So let's start by the carbon dioxide, because it's easier actually. The factors affecting the carbon dioxide is actually the minute volume. So how much air will go in and out during a minute. and actually the minute volume, which consists of two factors, the tidal volume, okay, and the respiratory rate. These are the factors actually that affect the CO2 wash, okay, or the ventilation, okay, and that affects the CO2 level. So the more the minute volume, the less will be the CO2 level. So what affects the oxygen level then, or the PO2 in the ABG? So actually, the thing that affects the PO2 is the mean airway pressure. Mean airway pressure. And what is the mean airway pressure? It's the area under the curve of the pressure curve. Okay, if you can see what I'm drawing here, so the area under the curve here determines the oxygenation, or the PO2. So the more the area under the curve or the mean airway pressure in the pressure curve, the more oxygenation, the more so the more recruited will be the alveoli, and the more oxygenation will happen. Okay. The other thing actually that affects the oxygenation is the FiO2. So two factors affecting the oxygenation in mechanically ventilated patient. It's FiO2 and the mean in airway pressure. Okay, and as we said before, so the mean airway pressure is the area under the curve, and the FiO2, everybody knows what's FiO2. So how to increase the area under the curve in the pressure curve? Actually, plateau, one of the things that will increase the area under the curve. Because actually, for example, imagine that this curve goes up here and ends here, goes down immediately here. So you will lose this part of the curve. All right, so this part of the curve will be lost. So the mean airway pressure will decrease, and hence the the PO2. Okay. The other thing that can affect the area under the curve, or the mean airway pressure, is actually the beep. Because imagine, for example, if this is the beep, if you put the beep here, this part of the curve will be added, okay? And if you remove the beep, this part of the curve will be taken out. So if you added beep to this curve, the whole curve will be taken up, okay? And this part will be added. So beep will increase, adding beep or increasing beep will increase the area under the curve. That's why increasing beep will recruit more alveoli and will increase oxygenation. And we do this actually in hypoxic patients, okay? So increasing FiO2, increasing beep, adding plateau to your ventilation settings, all of these things will also increase the area under the curve, and will increase the mean airway pressure, and will make the oxygenation better. So this is the first thing about the plateau, or the post-inspiratory hold. The other thing actually is that the barotrauma and volutrauma, both of them are related to the plateau pressure, which actually reflects the pressure in the alveoli. So actually, if you look at the curve again, the peak pressure reflects the initial resistance in the airway, and the plateau pressure reflects the alveolar pressure. So all the studies actually that discussed the barotrauma and volutrauma, for example, in the ARDS network guidelines, they said that it's safe as long as you keep the plateau pressure under 35, for example. So it's the plateau pressure because it reflects the alveolar pressure. So the airway pressure, which is the peak, is not directly related to any barotrauma or volutrauma. It's the plateau pressure. So that's also another advantage of the plateau. Okay. Another thing is, if in case you get you added plateau on the pressure curve, okay, you can always see the difference between peak and the plateau pressures. Peak, which is the airway pressure, and the plateau pressure. If the plateau pressure is normal, for example in this curve, and the peak pressure is very high, the difference between of them, if it's more than 15 centimeter water, for example, that means there is a high possibility of airway obstruction. Because actually the peak pressure is caused by airway resistance, and that actually includes any blockage of the tube, okay, any bronchospasm, okay, so anything actually that can cause increased airway resistance. Okay, if both of them are high, like this curve, okay, that means that the alveolar pressure is also high. That means the compliance of the lung is actually got worse. So for example, in ARDS people, in COVID patients, or in pulmonary edema, so the compliance of the whole lung is impaired if both alveolar pressure and peak pressure, both of them are getting high. And this is another actually advantage of having the plateau pressure, to know the alveolar pressure and the peak pressure, or the plateau pressure and the peak pressure. So it's also useful to have a look at the flow curve. So unlike the pressure, which most of the time is on one side of the curve, it's only positive, the flow curve actually, because the patient get breathing in and breathing out, it gets two sides of the curve. So this, for example, if you are putting your patient on volume control mode, and the patient starts breathing in, so the flow will go into the patient, will suddenly raise to a certain value, and will stay there for a while until the ventilator delivers the full volume, and it's switched to exhalation or expiration. Actually, if there is no plateau time, okay, it will switch directly to breathing out. If there is plateau time, okay, the flow after flow in, okay, then the flow will be zero for a while for the plateau time, which actually means that the air is being held inside the lung for a certain time, okay. Then breathing out is allowed. Okay, this is the flow curve. The importance of having a look at the flow curve, that it gives you an idea actually if the expiratory time is enough for exhalation or not. So how do you assess this? So for example, if you get here breathing in and this breathing out, so all the breath come out, because you know actually that the flow velocity reached zero, so all of the air came out and stayed zero for a while before starting the next breath. Okay, if you have a look, for example, on this curve, so the patient has been breathing in and breathing out, and before the expiration ends, or before the flow reaches zero, actually the next inspiration starts with another flow in. This part of the curve, okay, it actually gives us an idea that there is some sort of air trapping, because the flow velocity didn't reach zero. So before reaching zero, the next inspiration started. So actually this also gives you an idea there is some sort of air trapping here. And if you have this, you need to increase the expiratory time by manipulating the IE ratio, as we explained before. Okay? So what happens actually if you get only this part of the curve and you don't have any other part on the other side? So that means actually that the flow in is okay, but the flow out is not being measured. Okay, and here comes the the problem with the flow sensor. If you have only the flow in side of the curve and the flow out is not there, so that means that the flow sensor is not working. So what actually the importance of knowing that the flow sensor is not working, and what's actually the flow sensor? So this is the flow sensor, okay? This is the flow sensor actually of the Drager ventilators. The flow sensor is a part of the machine that actually feels the flow velocity on the expiration end of the ventilator. The problem is if this part is not working, and actually it happens commonly in the Drager machines, because this is the weakest part of the machine. Actually, the flow sensor is very commonly to get actually not working. If this is not working, the flow will not be sensed, and this is actually a major problem. Why? There's something actually maybe we didn't discuss, which is called the trigger mechanism. The trigger mechanism is how does the machine know that the patient is trying to take a spontaneous breathing. Okay, most of the machines nowadays are on actually a flow trigger mechanism. So that means that there will be a baseline flow after the expiration. So inspiration, expiration, between the end of the expiration and the beginning of the next inspiration, there is a baseline flow running inside the circle. When the patient started to suck air, okay, the flow within this circle will be interrupted. Okay, so the change of this baseline flow by the patient trying to suck air or to take air in to a certain extent, for example 3 or 5 liters per minute, the velocity of the air, if it dropped by 3 or 5 liters per minute, for example, so the machine will interpret this that the patient is trying to take spontaneous, and actually this will be converted to assisted, for example, and if there is an assisted breath to be given, or for example the pressure support. Okay, so if the trigger mechanism is not working, that means actually that all the modes that have any interaction to the patient will not work. It will work only as mandatory. So the assist control will be only mandatory, and the SIMV will be only mandatory, and actually the CPAP will not work if you are putting your patient on BiPAP, for example, on the mechanical ventilation. That actually more related to the ITU team, but who knows? It's necessary to know this. Actually, if the flow sensor is not working, all the modes that contain some interaction between the patient and machine will not be working. Okay, so that's why it's necessary to check the flow curve and to know that. By the way, we drew the flow in wave as a square, but actually it's not necessary to be a square at all. Different types of flow modes can be adjusted in the machine, as we will see in the real ventilator in the next picture. So that was actually a picture from a ventilator I took myself actually in one of my patients. And here, if you can see, so here is the flow curve and here is the pressure curve. And that's the main thing we want to discuss. So the pressure curve, the peak is 61, which is actually very high. So if you come here to see this, the pressure going up is going up to 61. 61. This is the 40, this is 80, this is 60, so 61. Okay. However, the plateau is only about 20, or even maybe less than 20. So the difference is actually 40 centimeter water. So that's actually, it's too much, isn't it? So anything more than 15 centimeter water difference between peak and plateau, that reflects a problem in the airway, either wheezy chest or blockage tube or whatever. For this patient, we had to change the tube because he wasn't wheezy, and when we took the tube out and we cut the tip of the tube and send it for culture, you can look at the tip of the tube in the next picture. And here we go. So the tube actually is almost totally blocked. You can see actually that's a blood clot everywhere, just leaving small opening here for the patient to breathe, and that's why actually the resistance was very high. Okay, and you remember the peak was 61 and the plateau was about 20 or even less. So once we changed the tube, okay, look at the next picture to know what happened in the peak and plateau pressures. Here we go. So actually, so the peak dropped from 61 to 24, which is quite significant. And the plateau pressure stayed the same because actually the lungs are okay. It's all about the tube that was almost blocked. Okay. So that's it actually. This is the part of the mechanical ventilation that is sometimes a bit difficult to understand when you read from the books. I will not actually going to talk about the initial settings of mechanical ventilation, how much should be the tidal volume per kg, 6 mils per kg, for example, and if you are in a protective lung strategy, and COPD exacerbation can be 7 or even more. Anyway, actually that we can read, and actually guidelines in this from this perspective can change time to time. So I just wanted to highlight the difficult points to understand the mechanical ventilation. So just to summarize, to sum up what we discussed today. So we discussed about what's ventilation, and actually that ventilation is air movement that's actually generated by pressure change. And we talked about pressure controlled ventilation and volume controlled ventilation, and we spoke about the different types of breath that can happen during interaction between a patient and the machine. So we spoke about mandatory breath, volume and pressure controlled. We talked about assisted breath, volume and pressure controlled, and we spoke about the pressure support. And we made a comparison actually between all of these in terms of initiation, target, and cycling mechanisms. Then we spoke about the basic modes of mechanical ventilation. Nowadays, actually, modes are changing and it's getting more complicated. So actually, it doesn't matter. So as an A&E doctor, for example, you need to know the IPPV or the assist control mode that you will use on our Oxylog or portable ventilator machine. Okay, so for this mode, for example, you need just to adjust the tidal volume, the respiratory rate, and the FiO2, which is normally 100%. Then you can titrate down to reach the target oxygenation. So don't forget, if you want to control the CO2 or wash more CO2, you need to increase the minute volume. And if you want to increase the oxygenation, you need to increase the area under the curve and the pressure curve, which actually you can see here. So you can increase it by adding a beep, okay, or adding adding a beep, or adding a plateau, or increasing the FiO2. Don't forget as well, if you are ventilating a patient, if you intubated and ventilating a patient who was in severe metabolic acidosis and actually working hard with pH, for example 6.9 or something like that, just put in mind that this patient is trying hard to wash the CO2 by maximizing his minute volume. That's why he's breathing hard. Actually, if you put him on the actually the normal minute volume of actually putting a breathing rate of only 12 and tidal volume of 500, so making just the minute volume of 6 liters, while actually he was taking more before intubation and ventilation, you are making things worse. So to maintain the pH of a ventilated patient, a pH for a patient who was in severe metabolic acidosis, especially the DKA people, so you need actually to increase the minute volume to keep it the same as before the ventilation. Yeah, it's also actually necessary to review the the recommendations for ventilating patients with COPD exacerbation. Ventilating patients with asthma is actually, it's really important to review the guidance. We can discuss it in a separate lecture. And it's also important to understand the pressure curve and the flow curve. The flow curve, actually, as we discussed today, this is the flow in and this is the flow out, and this is the plateau time with zero flow. Yeah, it's really important to understand why we are having this, and if the breathing in is starting before the flow reaching zero, actually that means air trapping. And actually, if you also get a difference between peak pressure and plateau pressure more than 15 centimeter water, just make sure your patient doesn't have any bronchospasm or actually blocked tube. I hope this lecture will make it easier for the ITU people and actually the A&E doctors to deal with ventilated patients. And thank you so much for your time. And I wish, actually, I hope if you enjoyed this lecture, to just share it to somebody else who can benefit for the sake of our patients. And thank you so much. I hope any questions, actually, you can write it down in a comment, and I will do my best to answer the questions. And